A 30-year-old man presents to the emergency department with acute onset of severe abdominal pain, nausea, vomiting, and altered mental state. One day before, he had developed fever, headache, photophobia, and purpura on lower limbs. His hypotensive, blood sugar is low, and hyperkalemia is present. How will you manage this condition? Adrenal insufficiency. It is the deficiency of adrenal cortical hormones, mainly cortisol and aldosterone. It can be acute or chronic. Acute adrenal insufficiency is a medical emergency. Classification: primary and secondary. Primary is due to adrenal cause and secondary is due to pituitary or hypothalamic cause. Primary adrenal insufficiency presents with hyperpigmentation, hyperkalemia, non-anion gap metabolic acidosis, whereas secondary adrenal insufficiency does not have these features because low ACTH does not decrease aldosterone, as aldosterone secretion is regulated by renin-angiotensin-aldosterone system. Etiology: primary, most commonly caused by autoimmune adrenal cortex destruction, known as Addison's disease. Other causes include congenital enzyme deficiencies, adrenal hemorrhage, also known as Waterhouse-Friderichsen syndrome, from Neisseria infection, and infections like HIV, histoplasmosis, and TB. Secondary causes include decreased ACTH production by the pituitary or decreased CRH production by the hypothalamus. It is most often caused by abrupt cessation of long-term glucocorticoid treatment, often during higher doses and longer duration of therapy. Clinical features: in chronic adrenal insufficiency, most symptoms are non-specific. Weakness, fatigue, and anorexia with weight loss are common. Hyperpigmentation caused by increased ACTH secretion and non-anion gap metabolic acidosis caused by aldosterone deficiency is seen in Addison's disease. Shock, hypotension, confusion, and coma is seen in acute adrenal crisis. Diagnosis: plasma cortisol, ACTH level, ACTH stimulation test, and MRI of head is done. Lab test shows hypoglycemia and hyperkalemia. 8 am plasma cortisol levels and ACTH levels are measured. An 8 am plasma cortisol level less than 3 microgram per deciliter in the absence of exogenous glucocorticoid administration is diagnostic of adrenal insufficiency. A synthetic ACTH stimulation test is the test of choice if morning cortisol levels are non-diagnostic. Failure of cortisol to rise greater than 20 microgram per deciliter following ACTH administration confirms the diagnosis of primary adrenal insufficiency. This table shows the basic differences between primary and secondary adrenal insufficiency, but the main thing to focus here is that in primary adrenal insufficiency, aldosterone is low with low sodium and high potassium, and in secondary adrenal insufficiency, aldosterone is normal with normal sodium and potassium. Adrenal crisis: acute shutdown of adrenal cortical hormones, fever, vomiting, abdominal pain, altered mental status, and vascular collapse may occur. This may occur in the following conditions: previously undiagnosed patient with adrenal insufficiency who has undergone surgery, serious infection, and major stress; bilateral adrenal infraction or hemorrhage; patient who is abruptly withdrawn from chronic glucocorticoid therapy. Get a cortisol level, then rapidly administer fluids and hydrocortisone in adrenal crisis. Differential diagnosis: must differentiate from mixed edema coma, which presents with similar features. So it is important to evaluate thyroid function test, especially in someone who already has hypothyroidism. Management of adrenal insufficiency: in primary adrenal insufficiency, glucocorticoid and mineralocorticoid replacement is done. In secondary adrenal insufficiency, only glucocorticoid replacement is necessary. Mineralocorticoid production is not ACTH dependent. In acute adrenal crisis, provide intravenous steroids, correct electrolyte abnormalities, provide 50% dextrose to correct hypoglycemia, and initiate aggressive volume resuscitation. Increase the dose of steroids during periods of stress. In patients on chronic steroid therapy, taper slowly to prevent secondary adrenal insufficiency. Management of adrenal crisis: remember 4S: salt, steroid, supportive, and surge. Normal saline is the best initial management. Intravenous 100 mg hydrocortisone is given and repeated every 8 hours. Must remember concept: dose of steroids should be tapered slowly. In periods of stress like infection, surgery, trauma, dose of steroid is increased. Steroids should be given as soon as possible in a patient with adrenal insufficiency. Most common cause of primary adrenal insufficiency is Addison's disease, but most common cause of adrenal crisis is abrupt steroid cessation. Now back to the case. The patient most likely has infection with Neisseria meningitis. He now presents with acute adrenal crisis due to adrenal hemorrhage, also known as Waterhouse-Fried resistance syndrome. The management includes 4S: salt, steroid, support, and search.